UAD, University of Zambia. Dr. Parham is not a stranger to the United States, grew up in Fairfield, Alabama, and he'll share his own story and how he came to this place as he moves forward. But we also have Ms. Claudia Hardy, who is working on in Alabama to eliminate cervical cancer in the Black Belt. And she will also share her experience and some of the stories of the people that she worked with. But before we move there, as a deacon of the 16th Street Baptist Church, we also have Pastor Arthur Price on, but I guess he don't want to say anything. He can if he want to. But the 16th Street Baptist Church has always been on the front end of change in the world and in the community. Pastor Price, would you like to say just a word of welcome from the 16th Street Baptist Church?
Good evening, everyone. Welcome to our Health and Wellness Ministry seminar tonight on eliminating cervical cancer. Dr. Parham, we're so grateful and delighted for you to be with us on this day and for the invitation to have a 16th Street Baptist Church share in this very important discussion. Our Health and Wellness Ministry is about educating, enlightening, and of course, encouraging those individuals to take care of their health. So we're looking forward to a very fruitful discussion today, and we're very grateful for Deacon Townsend and Dr. Garrett for leading this charge. Welcome and God bless you.
Thank you, Pastor Price. I want to follow up now with Ms. Claudia Hardy. Claudia, could you unmute and tell us a little bit about the work that you do in the Black Belt and the commitment that UAB and the Alabama Department of Health has given to saving lives in Alabama? Ms. Hardy.
Hey, good evening, and thank you, Greg, for just allowing us to say hello. Actually, we just here as a guest, and we are here from the Office of Community Outreach and Engagement over at O'Neill Comprehensive Cancer Center at UAB. And having grown up in rural Alabama, below 17 miles south of Selma, so I know exactly a lot of the issues that women continue to fight. Been working in this capacity about 22 years almost, but I don't do this work alone. And so I'm gonna give a shout out to all of my local community coordinators. We implement or utilize a community health advisors model where we take lay people and we train them, and they are the foot soldiers. And so I don't share tonight's platform without that. I didn't know I was needing to say anything. So since I have to be in my official capacity, I thought I better act right here. So, but Darlene is here, Cordy is on, Dolores is on from the Black Belt. I have Glenda there. I see Pat Gillette all the way from Macon County. I see Sharonda as a community health advisor. I see Jeanette Anglin all the way from Barber County. We representing Eufaula. So these folks are foot soldiers on the ground. Greta Holster, we're in Walker County here. Chinwe Okiki from Dallas County is on. Kathy Levy is on from over in Choctaw County. I see Joanka Robinson is on from Shelby County. All of these are community health workers working with us to educate. They're out there on the front line. And so we have these individuals. Gloria Shields all the way from Mississippi, from Yazoo County. And then I saw Cordy Walker from Mississippi. And so if I missed anybody else that's part of the outreach team, you all know I don't mean that intentionally, but we are here. Dorothy McAdora, she and Reverend Pastor McAdora, they are there. They are out here with us. And so we're simple. We encourage our families and friends about getting screened. We promote the early detection program. Cervical cancer is a preventable cancer if we catch it early enough. So I'm gonna stop there, but thank you all. We are here in your back door. We're right all over the state. So whatever you need to help share messages, the community health advisors, the community coordinators, you all are here. Thank you, team, for joining. We got the message last night, and you all, I can't tell you enough how much I love and appreciate you all. That's true engagement, because all I do is make an ask, and when I tell you all, y'all show up, I appreciate you all. So love y'all. So thank you. Thank you, Greg.
Thank you, Claudia, for taking time to share a little bit about your experience and the work that you're doing in Lower Alabama. The Black Belt of Alabama is not called the Black Belt because the soil is rich. That's why it started, because it was fertile soil where they could grow crops and cotton and all those things, during the era of slavery. But now the Black Belt is dark because of the health disparities that exist in that area. Some of the highest rates of poverty in Alabama exist in that region of the South. And some of the highest rates of early death exist also in those communities. So hopefully we can talk a little bit about the social determinants of health, health inequities and health disparities that lead to early death for a lot of our women and families in Lower Alabama. Dr. Parham, again, we thank you on behalf of the 16th Street Baptist Church. I'm going to turn it over to you and let you come to the community in your own way. Again, thank you.
Great. Well, thank you, Brother Greg, and Pastor Price. Is so wonderful to be able to talk with you. I know it's afternoon for you. It's about 3:30 in the morning here, but it's great to be here. Great to communicate, and thank you for this opportunity. The topic today is really to talk about eliminating cervical cancer, creating hope tomorrow by investing in girls and women today. And so, Claire, are you there?
I'm here.
Okay, my next slide, please. So I wanted, this is not a very long talk, and I thought we'd, leave an adequate amount of time for questions and answers. But what I wanted to do, I wanted to tell you a little bit about myself and how I got to Africa, because I've been here for going on 16 years now, and what I'm doing with the WHO, the World Health Organization in Geneva, Switzerland. Just a short description of what is cancer, the causes, risk factors, and distributions of cancer across the globe, because we're really looking at this as a global problem. And how can cervical cancer be prevented? And just a bit about the WHO's recent launch, historic launch yesterday of the global strategy to eliminate cervical cancer. For me, it's yesterday. For you, it's today. And that's the first time there's ever been a global strategy to eliminate a cancer. I doubt it will be the last one. Breast cancer may be coming around the corner, but it was certainly a historic day yesterday to participate in the program with first ladies, the wives of African presidents, and all of the heads of the United Nations agencies, etc. And 16th Street Baptist Church had a great showing yesterday. So look, that's basically my outline. Next slide, Claire. So again, I'm Groesbeck Parham. I'm a gynecologic oncologist. I'm from Fairfield, Alabama. Did my medical school and obstetrics and gynecology residency over at UAB. Did my rest of my training out in California. And I presently serve two positions at the WHO. I'm the co-chair of the Director General, and that's Dr. Tedros from Ethiopia, who runs the WHO. The first time an African has been in that position. I'm the co-chair of his expert group on cervical cancer elimination. They're experts from all across the globe, and we meet periodically to try to develop policy and plans of how to push this thing forward. But I'm also the clinical expert, the international clinical expert for this elimination initiative for the woman who is in charge of it from South Africa, Dr. Nono Simelela, who I met some 30 years ago when I was working in South Africa. Next slide. So, in the center of this picture on the left is the African continent. And obviously you see to your left, North America, and probably half of that at the top is Canada. And then that's where you are. So what separates us is the Atlantic Ocean primarily. And then on the right side, let's see, let me pull your pictures down so I can see things a little better. It's where I am. I'm in a country called Zambia. If you look in the sort of the center near the bottom, you'll see the Democratic Republic of the Congo. And then you see this green, sort of funny shaped country called Zambia. And that's where I am right now. And I've been here for about 16 years with my wife. Next slide. And so this is a close-up of Zambia. You see it in beige. And so we're surrounded by 8 different countries, sort of unique in that sense. There are about 18 million people here. I live in the capital city. It's called Lusaka, about 2.5 million people, and it's growing pretty rapidly. Still, the majority of the population is rural, but about 40% of the population is urban. Like most African countries, the population is really young. The median age is 17. It's probably dropped down to about 16 by now. And that's Africa has a very young population. People don't live a long time here, but they're living longer now. When I first came here, the median age had dropped significantly, and the average life expectancy when I came here in 2003 was only 38 years. And I was in my 50s when I came. So I was an old man, but that's because the HIV epidemic was just ravaging this country. But things have changed now because of HIV drugs. So the median age is 17. Adult literacy rate is about 85%. There are about 27 different languages here, but English is the commercial language, so I don't have any problems communicating. Again, you can see the HIV prevalence rate is about 12%. And in Lusaka, that's for the country. In Lusaka, it's about 25%. So the HIV rates are high, and there's still over 1 million people living with HIV. Cervical cancer, unlike it is in the United States, which is way down the list now, is the most common disease. About 40% of all the cancers that we see in this country are cancers of the cervix. That's all adult cancers. Breast is second, probably at 12 or 13%. And probably 50 to 60% of all the cervical cancer cases that we see are in women who are HIV infected. And that's just because of this, relationship between HIV and cervical cancer. HIV puts women at risk for cervical cancer. Their risk of getting cervical cancer, a woman's risk of getting cervical cancer if she's HIV positive, even taking drugs, is 5 to 6 times higher than if she's HIV negative. And also, cervical precancer exposes women to the risk of cervical cancer because of that lesion on the cervix, and it provides access. The T cells there in that lesion, and it's accessed. They have receptors for HIV, and that's just another reason for screening women and getting rid of these precancerous lesions, because you can also help prevent them from developing HIV. But it's a big problem here. Next slide. And so what's interesting in this country, as it is in most countries in sub-Saharan Africa, is you have this really, it's not strange, but one is really linked to the other. So Zambia has one of the largest deposits in the world of copper and emeralds. Very, 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 very valuable minerals. But 2/3 of the population live on $2 a day, less than $2 a day. And according to the United Nations, that's the definition of severe poverty. That definition is less than $1.90 a day, and that's US dollars. But that's because the country does not own most of its natural resources. And once that changes, you'll see the economy begin to change. But it has the deposits of uranium and gold. It has vast agriculture, but it's not without wealth. It's not as wealthy as a country that's sitting north of us, which is the Congo. And I've done some work up there recently with Dikembe Mutombo, the NBA basketball player, which has the most, it's one of the, that's probably the poorest country in Africa. And it has the richest deposits of coltan, which is what your computers and cell phones are made out of, uranium, gold, diamonds, etc. Anyway, in Zambia, in the rural areas, most people do not have running water or electricity. And right now in Lusaka, we're like 12 hours on and 12 hours off of electricity. So I got my little extra battery operated things. My wife has hooked me up in case the lights go out. I'm surprised they're still on. But anyway, you adjust to the situation and you move forward. It's a great country. I love being here. Next slide. And so that's just a bird's eye view of the city of Lusaka. Next slide. And this is just a typical peri-urban community. And most of our cervical cancer clinics are in places like this. And this is where we started, in a place like this. This is a town, an area called Kanyama. And it looks a little better now because we had a really bad cholera outbreak a few years ago. And so the government became really stringent about cleaning some of these places up. But this is, it's the tough life here. And you can imagine what it takes to try to live off less than $2 a day. Now, that does not mean there's not a middle class here, but it's very small. It's growing. I could show you pictures of Zambian women that look just like you. There are places I could take you in Lusaka and take blindfold you. And when I took the blindfold off, you would think you were in Atlanta or in Birmingham. But that's the small percent of the population. There, people are educated. There are universities here. There's a growing tech industry, cell phones, et cetera, et cetera. But the population, the vast majority of the population is very poor. Next slide. And this is a typical, what we call peri-urban dwelling inside Lusaka. Just small places, and people have to fetch water, and sanitation is there's latrines. There are no toilets in these places. They're just latrines, and sometimes during the rainy season, which we are about to go into now, you can get some runoff of waste material into the water system, which is why we can get these bad cholera infections. Next slide. And this is a rural area. Like as I said, people don't have running water running into the houses. There are these community wells and community pumps. And so you still see women, primarily women and children, going to these areas, getting, 2 or 3 canisters of water a day, and they still take it back, walking with it on their heads. Next slide. And so, as I said, there's a growing tech industry in the city. There are universities, there are several malls around, but by and large, it's a hand-to-mouth existence. And it's particularly for women who, thrive on day-to-day agriculture. It was really interesting when we have COVID here, just like you do. Fortunately, it never really got out of control because the government jumped on it, and people live outside, and probably the temperature helped. We're in another peak now, but it never was as bad as it was in the US. And when the government tried to shut things down, I mean, it just didn't make sense, because if you're making $2 a day, you got to get out and sell these things. So, the vegetables and things that you sell. So you can't tell people to stay inside. It's just not going to happen. But this is, a typical marketplace. There are supermarkets now that are growing, that are sort of pushing these people out of business, and just as the banks are growing. So we'll see what happens. Next slide. So when I first came here, I, visited the medical school. There's one big medical center here called the University Teaching Hospital. Now there are two, but this was the maternity unit where we set up our first cervical cancer research study, where we took 150 women who were coming in who were HIV positive and coming in to get their HIV drugs, and we screened them all for cervical cancer. And 94% of them had abnormal pap smears, and 30% of them already had invasive cervical cancer. So I was able to use that small amount of data to get some money to start the cervical cancer program in Zambia, because when I came here, there was essentially no cervical cancer screening. There were 12 gynecologists in the country. There was one cytologist in the country. That's someone who would read a pap smear. There was one pathologist in the country. There was no chemotherapy. There was no radiation therapy. And there was some data. I came here in 2003, but up from 1964, when the country got its independence from Britain, up until 2000, about 4,000 women had been documented to have invasive cervical cancer. And only 350 of those women had been sent to surrounding countries to be treated with radiation therapy. So that meant, you know, the other 3,700 died without any treatment whatsoever. Next slide. So when I went into this place, I started making rounds. These are some of my great colleagues on my right-hand side, some of my best friends now. And what I found on the left was that 80% of the patients on the gynecology ward were reproductive age women. Now, obviously, I had seen women with cervical cancer, but they were mostly women in their 40s and 50s and 60s. But what was really unique and different about this experience, what I saw when I came here in 2003, was that these were young women. They were in their 20s and they had advanced cervical cancer. But I also found that most of these women were HIV positive. And in a woman who's HIV positive, cervical cancer just grows like wildfire. And this was actually just at the time when antiretroviral therapy was becoming available. So we would just see just hordes of women coming in their 20s and early 30s, and they just had these advanced cervical cancers, and there was no way to treat them. Next slide. And so, you know, just to make sure we're on the same page, this is, you know, female pelvic organs. Next slide. And so on the left-hand side would be the way a normal cervix would look. You see that arrow, that's the cervix, which is the mouth of the womb. But what we saw here, we saw these cancers, huge cancers coming all the way down the vagina. And these things are very difficult to cure, even if you're in the United States. So women were bleeding, they were anemic, they were HIV positive. So it was a horror story. Next slide. And on the left is a normal cervix. On the right, when we would examine these women, this is what we would see. And again, these are women at 25, 26, 27, 30 years old, you know, young women. Next slide. And then sometimes we would see, this is sort of a side view, in a significant number of women, probably in about 15% of the women we saw these things called fistulas. Now, if you look on your left-hand side, that's the bladder. And if you look on your right-hand side, when you see those big brown balls that's feces. And so the cervix has grown into the rectum and grown into the bladder. And so what we would see as a result of that, the cervical cancer had grown into the rectum and grown into the bladder. And what you would see in about 15% of the women coming into the clinic is they had feces and urine coming through their vaginas. Okay, now imagine that. It's a horrible existence. You're 25, you're 30 years old, and it's uncontrollable, and you're wearing bed sheets and whatnot. But this was cervical cancer in Zambia in 2003. But I had seen some of this before because I had visited Uganda, I'd gone to South Africa, I visited Tanzania. and they had these cancer wards. They were always out on verandas where the fresh air would come through because of the stench. And these were women who were out there dying of this. But initially when I went, there was the HIV crisis was out there. So this was now worse. Next slide. And so someone took me out, and Pastor, you would appreciate this. And I said, well, how do young people make money? And they said, they make coffins, that the church, there's so many people dying from HIV, that one of the things that churches do is they make coffins. And that's the way they make money. And next slide. And so when I saw that, that's when I'm sorry, Claire, go back one. When I saw that, that's when I stopped and made a decision that I knew something and had some skills that could make a difference in this situation. I was a cancer surgeon. I knew how to teach doctors how to perform surgery on women who had cervical cancer. I knew about cervical cancer screening. I knew how to train nurses to perform cervical cancer screening. I had learned from some friends who lived in neighboring countries that you could actually take vinegar and put it on the cervix. And if there was a precancerous lesion, it would turn white. And you could take something that had been abandoned in the United States some years before called cryosurgery. You could freeze that lesion. And I asked if they had any of that in Zambia, and people said, no, what are you talking about? Cervical cancer screening, there's no such thing. So that's where I guess I did what Booker T. Washington said. I guess that's when I decided to cast down my buckets and make a stand and go to Zambia and participate in the fight against cervical cancer as a frontline doctor, not just talking about it, not just educating people, but to build a system. Because what I learned is that, particularly in Africa, where the health systems are so weak, you have to build the whole system. You have to educate women, but you also have to have the clinics that they can go to. You have to train the nurses. You have to get all the equipment and make sure it's there. You have to work with the pathologists to set up the laboratory. You have to make sure you get the laboratory results back. You have to make sure women get transportation so they can come back in. And you have to have the equipment to treat them. And if you can't treat them for pre-cancer, then you have to at least, those cases that can be treated with surgery, you have to train people to do that. And so you have to have control of the whole supply chain, or else, you educate someone and where are they going to go? They got no clinic to go to. Or if they go to the clinic, there's no nurse, there's no one there who's trained. Or if they have to come back for a second visit and they're making $2 a day, they don't have the money to come back and sit in the clinic all day. So you have to have a transportation system. So I decided that I was going to try to work with my colleagues and build the entire system. And fortunately, the government was working at that time on developing chemotherapy and radiation, which is what you use to treat advanced cervical cancers. So what was left for us was education, setting up the clinics, finding money to get all the equipment, training nurses, because we didn't have enough doctors to do all this, and setting up the pathology labs. And so we learned quite a bit in doing this. And it was difficult. It was really difficult. My wife always talks about the fact that I never sleep. But the only way we did this was just staying up at night all day, all night. I mean, I lived and breathed this thing. My life was just consumed by it. Every minute of the day, I was thinking about, how are we going to develop a system for cervical cancer? How are we going to basically start from scratch? But with the grace of God and with the help of some other people, we did it. So next slide. So that's how I got here. And I left home in 2005, and I came here, and I'll never forget the day I had been working at UAB, and I had had enough of that. And I was lying on my mother's sofa in Fairfield, sort of half asleep and half awake. She had passed on. My kids had finished college. My wife was in the kitchen. We were at my mother's house where we were living. And I said this prayer. And I said, the prayer was, I said, dear God, because I didn't know where I was going to go. I was just sort of in limbo. And for my life, God has always likes me to be in limbo. You know, when I'm confused about where I want to go, that's when he catches me. So the prayer was this, and I'll never forget the prayer. I said, dear God, if you take me and put me in a place in the world where I can serve the most dispossessed women on the planet, I promise you I will go, and I will not return until you tell me to. I'll not return home till you tell me to. And on several occasions. And so I woke up and I went in the kitchen and I told my wife about the prayer. And she's a very religious woman. And she said, well, you better go in the room and pack your bags. I said, why you say that? She said, because when a man gives his life to God the way you just did, he's going to answer your prayer. He's going to challenge you. And this was on a Thursday. And on a Saturday, I got a phone call from an old friend. And he said, you know that country you went to visit? I said, yeah, Zambia. He said, yeah. He said, I got a job over there for you if you want it. And it was doing something with HIV. And I said, I don't do HIV, man. And he said, but it'll get you there. And it'll get you there. He said, I know what you want to do, but it will get you there. It was probably a fourth of the money that I was making at UAB, but I decided to go with my wife's support. And a few weeks, a couple of months later, I packed my bags and I went. And you know, I've never looked back since that time. So what is cancer? So cancer, one of the best ways I've ever been able to explain cancer, you know, we have these millions and millions of cells in our body that do all the things we do. Heart, you know, we need to do heart cells that pump your heart, kidney cells that make urine, liver cells that clean your blood, muscle cells that give you the strength, and, you know, bone cells in your bone that give you your body structure. Well, cells they're like factories, and they're highly regulated, and they all have this thing called programmed cell death. Different cells in your body are programmed to live a certain length of time, and then they die, and the place is taken by a new cell. For instance, your red blood cells only live 120 days, and then your bone marrow makes new blood cells. But those things die. The cells that are on your skin, they only live 3 to 5 days. So when you take a bath and you see that ring around the tub, that's dead. That's what we call dead skin. But those are cells, and they live out their lifespan. A cancer cell is, I say it's gone mad. It reminds me of the guy, and you've all seen these guys. I hope you don't have any relatives like this. I'm not being personal, but in the middle of the summer, you'll see someone standing on the street corner with an overcoat on and a hat and a scarf. And you look at that guy and you say, man, that guy's crazy. You know, it's 100 degrees out here and he acts like it's minus 20. And people say, well, he's gone mad. He's not thinking the way we usually think. He doesn't feel things, you know, he's not, his regulators are off. So a cell is gone mad because it becomes immortal. It doesn't die. It has that whole mechanism inside that says live for 120 days and then die is turned off. So it just continues to multiply and multiply and multiply and multiply. And that's one of the, you know, this whole thing about what you heard today about Henrietta Lack and the HeLa cells, you know, they're immortal. And hers had this mortality that was probably, you know, more profound, more exaggerated than most. So it just keeps growing, and the growth is uncontrolled, and it does not respect boundaries. And here's an example when I say it doesn't respect boundaries. Usually a cell or a clump of cells, once they get a certain size and they bump into another cell, they will stop. because they say, oh, there's something else here that needs nutrition and needs room to grow, just like me. And so they grow a certain size and then they stop. But a cancer cell has lost respect for its boundaries. An example would be if Brother Greg came home and had a nice home, which I'm sure he does, and he pulled his car up in his driveway, and everybody says, well, Greg's at home, everything, his house is neat and clean, God, blah, blah, blah. And then the next week, Greg comes home and he's parked in his neighbor's yard. And the neighbors say, well, what's wrong with Greg? And then the next week, his wife is in the neighbor's kitchen cooking. And the next week, she's got her clothes in the neighbor's washer and dryer. And then the next week, they've now moved into the house doing the same thing down the road. So you have no respect for other people's boundaries. And you just grow across because the whole thing that you're interested in is just yourself. It's a very selfish process. And what's interesting about a cancer cell is that it continues to grow until it kills the very thing that keeps it alive, which is the human body. Now, if that's not something gone mad, why would you destroy the very thing that you need in order to survive? So that's why I say it's a cell gone mad, but that's what cancer is. Next slide. So let's talk about some of the causes, risk factors, and distribution of cervical cancer. And I say, I'm sorry, here in Africa, this place was colonized by the British, so they pronounce a lot of the words like the British do. So instead of saying cervical cancer, they say cervical cancer. So you'll hear me switch back and forth. Next slide. So cervical cancer is caused by a virus. It's called the human papillomavirus. That thing has been around for millions of years. They found it in mummies. It's been around. It's a double-stranded DNA virus, and it is transmitted primarily during, well, there are over 120 types, but there are only a few types that really affect the female pelvis, and then out of those, there are just about 15 types that cause cancer. So it's not all of the HPV viruses. You can get them on your skin, and they don't really, cause cancer. But there's few types that are called oncogenic or high risk, and those are the ones that we test for now with the new screening test, HPV. And so it's primarily transmitted sexually, right? So men give it to women, but also women can transmit that virus to men. So sometimes I'm in churches and places and talking about cervical cancer, and so the women in the room say, well, it's the men that are giving to us. And my question, well, where do you think the man got it from? He got it from a woman. So the question is like, what came first, the chicken or the egg? Well, it doesn't matter. We're all in it together. But so it is a virus. It is primarily sexually transmitted through heterosexual intercourse, but you can get it through any type of sexual intercourse or any touching of the area. There are a lot of head and neck cancers now. We know due to people having oral sex. And so any type of, mucosa to mucosa, sexual organs, etc., that virus can be transmitted. But primarily, it's heterosexually transmitted from men to women, women to men. Next slide. And you can't see this virus. And if you're infected with it, unless it causes a wart, which is something benign, a little skin tag, which can be really bad in some cases. I could show you some and you'd think they were horrible in places where there's no medical care. But they are asymptomatic. So a woman or a young girl becomes infected with the human papillomavirus, she does not know it. It does not cause discharge. It does not cause bleeding. It does not cause pain, which just tells you why you need to get screened, because you're feeling fine. And most of us think that, we don't have to go to the doctor until we start hurting or start bleeding. But by that time, is, you know, you already have the invasive cancer. So anyway, so what are the risk factors? Since it's sexually transmitted, early sexual intercourse. The earlier you start having sexual intercourse as a woman, the greater the chances you're gonna eventually interact with a man who has that virus, and he'll pass it to you unprotected intercourse. Condoms help, but they're not 100%. You can still get the virus. A man can have the virus on the skin around his testicles, and then rub up against the outside of the woman's vagina, and then it can go up the vagina into the cervix. So don't let condoms fool you. Multiple sexual partners, again, the more different men that a woman has sexual intercourse with, the greater the chances she's going to eventually have sex with a man who has the virus. Multiple childbirths, same thing, but also there's something that is sort of immunosuppressive about pregnancy. If you have a wart during pregnancy, it can really get big, and right after the pregnancy is over, it'll decrease in size. HIV infection, as I already talked about, is a big risk factor for developing cervical cancer. And if you've never been screened before and you're sexually active, you're at risk for getting it. And poverty. His brother was talking about the social determinants of health here, the social determinants of cervical cancer. That sitting at the center of that is poverty all across the globe, no matter where you are. You go into the, and I'm not saying that rich women or middle-class women can't get cervical cancer, but when you look at the real burden of this disease, it's highest in places where the income is lowest. Next slide. And so each year, in terms of the distribution, about 1.5 million new cases of cervical cancer and 300,000 deaths. That number is not really reflective of reality, because most of the places across the globe where cervical cancer rates are highest, they don't have cancer registries, or they don't have good cancer registries. So these are extrapolations from countries nearby that may have them. Zambia is just put one in place a couple of years ago. So most of us who are working here on the front line think that those numbers are probably twice as high. 8 in 10 women diagnosed with cervical cancer live in low-income countries like Africa, Asia, Latin America, and 9 in 10 who die live in the same very low-income countries where women are making $2, $3, $4 a day. Then you get in a place like sub-Saharan Africa, where I am, which is the epicenter of this disease. It's the second most common cancer. And it was the most common cancer, but was just surpassed by breast. But it's the most common cancer, second most common cancer, but it's the #1 cause of death, cancer-related death. So we see a lot of women dying from cervical cancer. That, if I would say there's one thing that has impacted me most since being in Africa, is the number of people who just die. Death is just so common here, not just from cervical cancer, but from HIV, from measles, from polio, from infections, from poor nutrition, from poverty. Death is just, every time I make rounds in the hospital, there's some patient I saw the previous day, and she, now she's dead. And I see women come in my clinics all the time, and as soon as they walk out the door, I know they don't have one inkling of a chance of living, because the disease is too advanced. Again, over 1/3 of all cervical cancer deaths in the world occur in sub-Saharan Africa. Over 1/3 of all the women who die in the world, those women are in sub-Saharan Africa. And women all over the world are the cornerstone of the family. They're the center of the family. But here in Africa and in very poor countries, they are really the solid foundation. They make it all happen. And I'll show you some statistics. They protect the children from diseases. And when women die, the chances that their small children are going to get educated drops significantly, and they get exposed to all kinds of diseases and other things that can happen in the community. So, you know, the woman is the foundation. If the foundation crumbles, the house eventually falls. So this is why this global initiative to me is so important, because without it, Africa and Asia and Latin America, these countries will never move into the future. They're going to always stay very weak. And so, because women are just so critical to the families, to the communities, and to the strength of the nation. So this is more than about a disease. This is about trying to protect somebody who's critical to the health of the nation. Next slide. And so this is just a map, a world map, and it shows you how cervical cancer is distributed across the world. So the darker the color, the higher the rates of cervical cancer. So you can see dark blue primarily in all over the African continent. You go to your left, you see some in Latin America, and you see some in Central America. Or on the right, you see some in Asia. You know, in the United States, it's low. So just to give you an example, in Zambia, the cervical cancer rates are something like 66, just say 70 per 100,000 women. In the US, it's like 7 or 8. So we're 10 times worse than what you are. So it's and probably more than that. Next slide. Next slide is just going to show you the same thing about death rates. You know, where the colors are darkest is where the death rates are higher from this disease. So you can see where the epicenter is. And I could show you a map. I could overlay this with a map of HIV, and it's almost exactly the same. I could take a map of tuberculosis, and it's almost exactly the same. I could take a map of where there are fewer doctors and fewer nurses, and I would say the darker the color, the less the numbers of healthcare professionals, and it would look exactly the same. If I showed you income and said the darker the color, the lower the income, it would almost be exactly the same. I've taken these maps and I've put them on top of each other, and I've closed my eyes and given them to people and say, close your eyes and figure out whether this is TB or malaria or cancer or HIV, and you can't, because they're basically the same. Next slide. Now, here's the US, right? And this is some data from 2017. I was trying to find some 2020 data, but didn't have time to find it. But the places where the colors are darkest are the places where the rates went per 100,000 of cervical cancer are greatest. And you see Florida, Alabama, Mississippi, Louisiana, Texas. You know, then you got Wyoming, Nebraska, places like that. And from what I read recently, Alabama and Mississippi have are sort of neck and neck, and you know, have 1.5 to 2 times the death rates of cervical cancer compared to other parts of the U.S. But this is where you fall. Next slide. And then this was some other information about just showing you in the U.S. What ethnic groups, how it breaks down in ethnic groups, rates per 100,000. So Hispanics look like they're a little higher, and then blacks, and et cetera, et cetera. Asian Pacific Islanders are 6. And so the highest is Hispanics and African Americans. Anyway, next slide. So how can cervical cancer be prevented? And this comes down to this whole, what the 3 pillars of the global strategy to eliminate cancer as a cervical cancer public health problem is all about. Next slide. So on the left-hand side, at the top row, these are just drawings. On the bottom row, these are real pictures that I took from patients that came to my clinic. So on the left-hand side, you see a normal looking cervix. And this is the way it looks to a gynecologist or a nurse, right? That little slit in the center is where it's called the os. That's where babies come out. And that's where, when you're younger, during your menstrual cycle, that's where the blood comes. But that's cancer of the, that's a normal looking cervix. It's a healthy looking cervix. In a woman who's had children. I can tell she's had children because it's sort of an irregular slit. When she hasn't had children, it's really small and round, like a little, circle that hasn't had any trauma to it. Then woman has sexual intercourse, young girl has sexual intercourse, she gets HPV infection. So if I put vinegar on the cervix of a young girl who has an HPV infection, I'll see something like that little white spot down there. But it doesn't look very bad, and it's not very large, and doesn't look, and for someone who's not a clinician, that doesn't, you wouldn't be able to make that distinction. But I would look at it and say that's a low-grade lesion of probably HPV. And from the time she has sexual intercourse to the time something like this shows up, it can be anywhere from 6 to 8 months. It's not very long before it takes. Now, the vast majority of women, if they get infected with HPV and they have a good immune system, it gets rid of it. And that's where the healthy part comes in. Getting sleep, getting rest, not drinking alcohol, not smoking, eating a lot of fresh fruits and vegetables and beans and grains and building up your immune system, it will get rid of this virus in 80% of the women. So if young women come to me like this and all they have is an HPV infection, I don't treat it, because you can't treat it. We don't have anything to actually treat the HPV, this viral infection right now. We can give a vaccine to prevent it, but we don't have what's called a therapeutic vaccine, something that treats it or something that can give it. But a strong immune system will get rid of this. A woman who's HIV infected, who's immunosuppressed, who has a weak immune system, she can't clear this virus. It will not go away in the vast majority of them, which is why the rates of cervical cancer are so much higher. Even if she's taking her antiretroviral medications, it won't have very much. It has some impact, but not very much. Okay, now if this viral infection persists, if your immune system doesn't get rid of it, then it moves to the third picture, which is a precancer. Now that's a bad boy right there. When you look at that lesion on the bottom, that's something that alarms me. It does not look like cancer, but it is a precancer, and it looks bad, and it's high grade, which means it's going to turn into cancer. So to get from the second picture, so to get from the first picture to the second picture, HIV infection, HPV infection, it takes about 6 to 8 months. To get from the second picture to the third picture, that is, you got the infection, your body doesn't clear it, now it persists, that infection persists and causes abnormal changes to the cells and is turning it into a precancer. That's 3 to 5 years, okay? Still, none of these have symptoms, no discharge, no bleeding, no pain. You can walk around with what's in that second picture on the bottom. You can walk around with what's in that third picture on the bottom, and you'll never know you have it unless you go and get screened for cervical cancer. Then we go into the last phase of this of this development of cervical cancer, which is the development of the cancer itself. So if nothing is done to get rid of that white area, that precancer in the third picture, in another 5, 10, 15 years, it develops into cancer. Now, in an HIV positive woman, it can take just 2 or 3 years. We've seen this thing just grow like fire. This whole process usually takes 15 to 20 years. But in an HIV positive woman, it can take 5 years, particularly if she has poor nutrition, she's malnourished, which a lot of women here malnourished and they have HIV infection, which is why we see the rates are so high. Again, social determinants, right? So once you get this last picture on the left, that's when you start having bleeding, and it's commonly bleeding after sexual intercourse or bleeding in between your menstrual periods or prolonged bleeding. You know, usually if your menses last 3 or 5 days, now it's 6 days, 7 days, 8 days. Now it's not stopping, or you start having pain. You have a problem. So this is the process of cervical cancer. This is how this thing develops over time. So now I'm going to show you so if you were, I'll just do it now. If you were going, let's go back to the left picture. If you wanted to stop or prevent the HPV infection, if you wanted to stop this infection, you would give a vaccine to this young girl. And so if when her cervix is normal, and that's usually prior to the time she has sexual intercourse, which is why they say between ages 9 and 14. You know, where I am in Zambia, you know, sex starts early, you know, 9, 10, 11. So you got to catch these young girls early. So this is what you would do if you wanted to prevent cervical cancer. If you wanted to prevent HPV infection, you would give the young girl a vaccine, HPV vaccine, and thus she would never get this HPV infection. Okay, so that's ultimately primary prevention right there. So that's where you would come in. Now, let's go to the third picture, right? If you want to prevent this precancer from turning into a cancer, this is where cervical cancer screening comes into the picture, because you want to pick this lesion up when it's still precancer, right? It's too late to give this woman a vaccine. She already has the HPV infection. So vaccines won't work because vaccines are preventative. They prevent the woman from getting an HPV infection. They build the immune system up, so when the immune system sees that virus, it automatically attacks it. That's over here. That's why vaccination is so important. But if she's she's already started having sexual intercourse, that's the woman that needs to get in to be screened. Okay, so you can, if she has this abnormality, you can pick it up and treat it. And you can treat this in the clinic. It takes me 10 minutes to treat this, get rid of this, so that it won't develop into cancer. Now, if it develops into cancer, she needs to be treated. And if the cancer is caught at an early stage, and that usually also happens when you go to a screening clinic, it can be removed surgically and cured. But it requires a hysterectomy. Or if it's advanced, you're going to have to get chemotherapy and radiation. And still a significant number of those can be cured if you have that kind of technology, which in here is, half the countries in Africa don't have a radiation therapy machine. The machines break down. The governments can't pay to get them fixed. So we have a cancer hospital, but half the time the machines are down. Right now, we can't get chemotherapy because, there's an outstanding bill that hadn't been paid for the chemo. So we have this great cancer center, and sometimes it's not functional. It's functional maybe 9 months out of the year at best. And so you can start treating women, and then the machine breaks down and they can't get fixed. And you can imagine how frustrating that is. Anyway, so those are the three things you would do. You would go back, you would give an HPV vaccine to the girl before she's sexually active, before she has sexual intercourse, and you can stop her from ever getting the virus. So if she doesn't get the virus, none of this happens. Or if she's an older woman, she's already having sexual intercourse, you say you need to get screened for cervical cancer so we can find it when it's still a precancer and get rid of it. Now, if she has a cancer, then that's when you treat it. Now, there's one thing I left out, and that is there's something else that young girls can do if they don't want to get infected with the HPV virus, and they can abstain from having sexual intercourse. So if you have daughters or people in your church and you think they can abstain, if you want to pursue that path, that's an option. if you think that can happen. And I'll just stop right there, because that'll work for some people. So that's an option, lifestyle. Next slide. So this is why the global strategy to eliminate cervical cancer is based on these 3 pillars: HPV vaccination, screening, and then treatment of cancers. Next slide. So they say the global strategy is that by 2030, they want all countries to be at a point where they are, so you got 10 years to do this, 90% of the girls are being vaccinated with HPV. Girls with HPV vaccinated by 15 years of age. So girls between 9 and 15, 9 and 14, 90% of them, the goal is to get 90% of those girls vaccinated with the HPV vaccine. And right now, there are about 106 countries in which vaccinations are taking place. And I just got this data from a pharmaceutical company yesterday, and it looks like overall about 68%. So that right now you get 2 doses of the vaccine. Now there's some research going on where it looks like 1 dose may be effective. So first it was 3 doses, now it's down to 2, and maybe it's down to 1. But right now, about of those 106 countries in which girls have been vaccinated in the world, about 68% have received the first dose, and about 53% have received the second dose. And only 5 out of the 106 countries have reached this 90% of girl, 90% target. So there's a lot of work to do. So 90% of girls, that's the first thing that the global strategy says. Then it says women at age 35, then again at age 45, when you find these precancers that are, when they're most prevalent, 70% of those women should be screened. So if you were running a campaign, you would say, my campaign is to vaccinate 90% of all the girls in the community between ages 9 and 15. And all women who are between ages 35 and 45, I want to screen you once at age 35 and screen you once at age 45 with an HPV test to see if you have the HPV. And if you're positive, then we need to do some other things. I would also say, of all the women who are screened, if we find precancer or cancer, we need to treat you. We need to treat the precancer. We don't need, there's no sense in finding a precancer and not being able to treat it. There's no sense in discovering a cancer and not being able to treat it. And we fail here quite a bit. We talk to women, we say, go in and get screened. They get screened and they never get treated. Or we talk to women and they go to the clinics and, there's a big problem at the clinic. People don't treat them right. They get confused. And so they never get the test, or they get a test. And you say, well, you need to come back for the second visit. They don't come back to the second visit. This is why I said when I came to Africa, I wanted to control the whole process, vaccination, screening, treatment of the precancers, and treatment of the cancers. That way I knew I had all of this. I was setting up a system to make sure all of this worked, and it has. Now that system, by the way, has gone from 2 clinics to now 162 clinics, and we've screened over 1 million women in the country, and we've trained several surgeons and have a radiation therapist. And so it's the biggest cancer prevention and treatment program on the continent of Africa. But 15 years ago, we didn't have anything. And it's totally run by the government now. But these are the 3 targets. And they want that the WHO is saying to countries, take 10 years to put everything in place so that by 2030, you are doing this. You are vaccinating 90%. You are screening 70%. You're treating 90% of the precancers and cancers. Now you have to keep going, but it's that you have 10 years now to do whatever you need to do, to raise the money, to politic, to put pressure on your your congressmen and your senators and the public health people, and to do whatever you need to do to get the ball rolling. And by 2030, if you're at this point, you will then start seeing a significant drop in the rates of cervical cancer in your country and in the death rates. And I'll show you a diagram with a group of very sophisticated modelers. You know, they can predict things. They'll show you how this thing can drop significantly. But you got to get to this point before that, and be ready to go. You got to be at this point by 2030 for that happen. And the goal is to get it down to 4 cases of cervical cancer per 100,000 women years, right? And where did this goal come from? This goal came from countries that have done this, and they're the most effective countries in reducing cervical cancer. And that's in places like Finland and Norway and Sweden, Australia looks like too. So this is the goal. This is best that mankind has been able to do so far. So, you know, we're at 80 per 100,000. You're at 8 per 100,000. So we have a long way to travel, you know, before we get here, and most countries do. Next slide. And so it's the same thing. If you were going to, you know, here's the normal cervix, here's HPV infection. So you want to vaccinate 90% of all girls so you never get this. And then here's the pre-cancer. And if you can screen women, 70% of all women, you'll never go from pre-cancer to cancer. And then if you do find this cancer, you want to be able to treat 90% of these women. So 90, 70, 90. 90% of the girls vaccinated, 70% of the women screened, and 90% of the women who have pre-cancer and cancer treated. That's the global strategy. Next slide. Now, this was the first little girl in Zambia to get vaccinated. This was years ago. This was a fabulous event. All the big dignitaries in the back. Her mother, this is her grandmother on the left, and she's a chief. She's an African chief. The African chiefs all over the country. One of the things we did was go out and talk to the chiefs and traditional healers. But this is the first little girl to get vaccinated in Zambia. This was, I guess, maybe 2008. Next slide. And if you have a pre-cancer like this is this white area, we have you have clinics where you can take these devices and remove this in the clinic. Next slide. And get rid of it so it don't develop in the country. So here's what I was talking about. If nothing is done, this is in the 78 countries, the poorest countries in the world, where the cervical cancer rates are highest. If nothing is done, if things stay the way they are, if girls are not being vaccinated, women are not being screened, and women are not being treated, you're gonna find the rates of cervical cancer just rising like crazy. But if you can put this by 2030, if you can start, if 2030 you're vaccinating 90%, screening 70%, and treating 90% of the pre-cancers and cancers, over time, you're going to see this is like 5 million, 15 million, 20 million, 30 million, 50 million. So at the end of the day, you know, between now and 2120, you will save 71 million lives. Next slide. I think I have a slide that shows you that. Next slide. Yeah, 70 million cases, new cases of cervical cancer can be averted by 2120. And the numbers may be in the rate of decrease may even be better than this. But we're talking about saving lives, and there's evidence that it can be done. Next slide. I'm almost done. So, you know, my feeling about this is that, yes, we need to vaccinate. Yes, we need to screen. Yes, we need to treat. But I think we also, as I said yesterday, we're going to have to deal with the social determinants of this disease. We're going to have to deal with the living conditions of women and girls in these countries because that's the breeding ground. These are the things that put women and girls at risk for getting HPV infection and not being able to get treated. They struggle every day for food, clean water, and clothing. I can't tell you the number of women I know who tell me that every day, Prof, is what they call me, Professor Prom. It's every day when I wake up, the first thing on my mind is, how am I going to feed my family? What am I going to do? Am I going to sell vegetables? Am I going to do this? Am I going to do that? How am I going to get clean water? How am I going to put clothes on my kids, the ones that need to go to school? Indecent shelter is the norm. I mean, people live in places that are just not fit for human beings. Latrines in a lot of these places, just holes in the grounds, no sewer systems. I mean, we figured out how to get sewage away from where we live 100 years ago. There's no reason why homes shouldn't have, sewage systems. Human beings can't live around their waste material. And that needs to be solved. Domestic abuse is a big problem in these countries. Alcoholism is a big problems in these countries. And women have little protection legally from domestic violence. I've been in some places and I've seen it, and it's horrible. And early childhood marriage can be part of the tradition out in rural areas. The girls are very valuable. If a man has a daughter, that daughter, is married off, and he gets something in return for that. So girls marry at age 8, 9, 10. And sometimes they marry men who have multiple wives, or they're older men who are, HIV infected or HPV infected. And so they're trapped in this thing for the rest of their lives. So early childhood marriage, gender-based violence, and there are movements within these countries to stop all of this. But these are some of the living conditions of women and girls in low-income countries that put them at risk. And I can also tell you that a lot of my patients tell me this, and they've been telling me this for years, that sex can often be the only readily available means for generating personal income and income for their family. It is not that these are necessarily promiscuous women, or, what we would call, it's not even commercial sex workers, but it's using sex to stay alive, using sex to survive, using sex to supplement, selling vegetables or whatever they need to do to take care of their families. The first thing on their mind is, when she wakes up in the morning, what am I going to do? What do I need to do to take care of my family? And whatever she needs to do, she gets busy doing it. Next slide. And so there was some recent data to come out about women who die from cervical cancer and what impact it has on their children. And this is for breast or cervix. In poor countries, they were able to come up with this data. Very nice study that was done by the World Health Organization. It was a modeling study. For every 100 women who die from cervical cancer in these poor countries, an additional 14 to 30 children will also die. That's how important this woman is as a protector of her children. If she dies, that little girl right there, let me show you what she's going to be exposed to. Next slide. Let me show you what she's going to die from. She's going to die, and this is what they die from. They don't die from anything that they usually don't die from, but more of the children die from malnutrition, diarrhea, dehydration, measles, and pneumonias. This is what kills children in very poor countries in Africa, Asia, Latin America. That mother helps to protect them from these diseases, these malnutrition. She makes sure they get food. She has diarrhea. They make sure they get to the doctor and that they get hydrated. They make sure they get vaccinated against measles, that they're sitting there and the babies are having problems breathing. There's a mother that says, take that baby to the clinic. That baby's sick. So she is the protector. So once she goes, once she dies, These are the diseases that stalk these children. So it is not just her children, it's her brother's children, it's her sister's children, it's the other children in the neighborhood. We like to say it's the children in her halo, particularly in extended families where older women have a lot of power and a lot of influence. So we're just not, again, keeping that woman alive, as poor as she may look, and as insignificant as you think somebody may think she is. She is the foundation of the nation, because without her, these children are going to die, and without her, I'm just about done. And
okay,
so so that's it. Next slide. I think that's all. My next slide. I think that's it. So I'm done. Thank you very much.
No, Dr. Parham, great. I want to stay on for a little while. I know that we've gone over time, everyone. However, there may be a few questions. If anyone has a burning question, we may take one or two of them. If you have to leave, we just want to tell you that we really appreciate you for taking time to share with us, join us in this conversation. It's been fruitful to me. I know it's been fruitful to others, and maybe we'll do it again very soon in the future. If you have a question, unmute yourself and just ask the question right quickly, if you don't mind. We'll take one or two.
I had a question.
Yes.
Unmute, Asia. Unmute.
Oh, can you hear me now?
Yes.
I just wanted to know, based off of your practice and where you're currently at, how often are you screening women for or doing pap smears, and what timeframes are you having them come back with a normal pap smear?
Well, we don't use pap smears. We don't have the laboratory to do that. We use what's called visual inspection with acetic acid, which is vinegar. We put vinegar on the cervix, and right now, and the WHO is redoing those guidelines. They'll be back out. They'll be in a year. But for an HIV positive woman, she should be screened every year. For an HIV negative woman, every 3 to 5 every 3 years. That's with this vinegar test. If it's an HPV test, every 5 years if she's HIV negative, but every probably 2 or 3 years if she's HIV positive. So HIV positive women need to be screened more frequent. That's the bottom line, and that's what we're doing. But we don't do PAPs. You'd have to abide by whatever it is in your in the U.S. and there are several guidelines that are there in the U.S. You just have to see what they are.
Okay. All right. Thank you.
You have another question?
Dr. Parham, great information, great presentation. This is Pastor Price speaking.
Yes,
it's interesting in your presentation. It seems as though that not having access to healthcare or even access to money puts people more at risk. And some of the, as you were speaking, it seemed like there were a lot of similarities over there that still exist here, believe it or not. But my question is, with the WHO trying to get a 90% by 2030 vaccination here in the US, African Americans are reluctant to take a vaccine that's given out by medical field or the government because of Tuskegee and some other things. Is that the same issues over there as well? Or do you think that you will be able to reach that 90% by 2030, even with the reluctance of people wanting to take a vaccine?
Yeah, ours here is not so much reluctance. It's just a shortage of the vaccine and the expense. Most people here, you know, cervical cancer is so common that people have seen that disease and they don't play around with it. And this whole thing of, you know, the vaccine making people, women, young girls sexually promiscuous is, I mean, that's what, you know, that's really not an issue here. But it's access to the vaccine and getting it at a price that's affordable. And if we can get enough of it, and it can be, you know, then we can do it. But it's not the same as you have there with the concern about Tuskegee and, you know, it being something that's going to harm. I mean, the vaccine is very safe. I've looked at it over and over again, but you know, if people don't believe it, they don't believe it. So no, it's different. It's different.
Forgive me if this has already been asked, but my question was if there's an opportunity for those of us who are in the trenches with this work already, even though COVID-19 is upon us, is there an opportunity for us to volunteer virtually, even from the States, to help contribute to some of this good work that you're doing?
Absolutely. Brother Greg, you have my email address, right?
Yes.
Please give anybody who wants it, please just give it to them, and you can write me, and I can share with you some things that I think that, you know, may be helpful where you can get involved. Absolutely.
Awesome. Thank you so much.
You're quite welcome.
Do we have another question?
Greg, I don't have a question, but I do want to share with the attendees who are not affiliated with with our work already that the HPV vaccination is readily available here in Alabama and in Mississippi at our local health departments. For women who don't have insurance, they can go through family planning to get the HPV vaccination, and they can get the screening. And so the recommendations are there as well. So there are a couple of issues here, piggyback on what Pastor Price mentioned. In addition to the access, we also have a lot of cultural beliefs. We also have a lot of value systems about what this vaccination and even follow-up. So as Dr. Parham mentioned, all of you on the stages of precancerous cells all the way to advanced cancer. We lose a lot of women for a lot of reasons when they don't go back after that first abnormal PAP here in the United States. And so hence our numbers don't look well, and our women are getting this disease and dying from it. But for all of us on the trenches, on the front line, we should be educating our daughters, granddaughters, nieces and nephews, anyone you know who's between ages of 9 and 13 or before they become sexually active, they should be getting the vaccination. And we're running into, as Dr. Parham said also, we're not giving our children permission to have sex. They were created to have sex, and they're going to have it anyway if they live long enough. But what you want to do, this is the one thing that we can prevent, and has been studied safely and it's tested. But we also know that many of the pediatricians also are not advocate. They're not even bringing it up. So as parents, ask for it. And we can prevent this just like we did polio and measles and mumps and rubella. But these services are available. We need to take advantage of them. Some things have been delayed a little bit because of COVID. But if you all know anyone who has issues getting in it, I'll drop our information locally for anybody locally who needs the information.
Yeah, Claudia, put your information in the chat if you don't mind. Everybody, I just want to thank you again for joining us this evening. Dr. Parham, do you have any closing remarks?
No, I don't. It's just good to see everybody from home, and Pastor Price, if I ever get on the airplane again, when I come back to Fairfield, which is where my home house is, I'll come see you in the congregation.
Look forward to seeing you. Thank you again for a wonderful presentation.
Right.
Again, everyone, this concludes this presentation. We thank you, and just look forward to the next event that we have in the future. So thank you, everyone. Take care and have a good night.
Bye-bye.
Thank you for having us.
All right, you're welcome, Claire. Claire, let's have some feedback soon.
Yes.
If we can. Let's do that.
Definitely. If you can share the recording with us.
Yes.
We're trying to like collect all of the different activities we're having, and so if we can, we'll even link it to our website.
We'll actually try to post it on our website.
Oh, that's
at the church, somewhere, so everybody can join in.
awesome.
Too. So again, thank you all, everyone. I'm closing you down. Thank you. Take care, everyone.
Will there be a part 2? This was so well done tonight. I was so impressed.
Hey, we'll be talking about it, and we'll find other topics that we can share with the community. But again, thank you for this one, and please leave me your email address in the chat.
Okay, will do. Thanks so much.
Thank you.